Hey, thanks, Sebastian. Hello to everyone. I'm really happy to be here to speak. I was really fortunate the whole you asked me to do this today, and I'm happy to be here with all of you. I'll just start with a little bit just about myself so you can put my presentation and thoughts in perspective. I'm a runner and a UW sports medicine physician, as Sebastian mentioned, who treats and cares for runners and other endurance athletes like triathletes and cyclists. I really briefly started running when I was 11 and haven't really missed a year since. I ran for my high school and college teams and then ran my first marathon in medical school in Chicago in my 20s. I continued, thereafter to run for enjoyment and a little competition still. Because most of my social circle was mainly runners and triathletes at that point in my life. I ran my last marathon when my 10-year-old son was 6 months old. And after that, I ran more recreationally with a baby jogger. Now that my kids are in elementary school, I enjoy ultra running on trails and in the mountains and have some fantastic excursions that I've done through Yosemite and the Wonderland Trail that just brought back great memories around Mount Rainier. But my favorite place still is just to run on Lake Washington Boulevard, though, here in Seattle. Now, I've been really lucky to combine my avocational interest or running with my vocation as a physician. And again, back in medical school in Chicago in the mid 1990s, I volunteered for the Chicago Marathon medical team, which was my first foray into marathon medicine. I took a faculty position here at the U in 2001 and began working with the Seattle Marathon as their medical director about 17 years ago or so. Though I've mostly been involved with the Seattle Marathon Association and our race here. I've worked as a medical provider for many other marathons, including Chicago and Houston, and a few triathlons as well, too. The Ironman 70.3 race that used to be in Maple Valley for the last 3 or 4 years. And now I think just maybe last week or this weekend, it's going to be in Richland, Washington, so in the Tri-Cities. I've worked for Ironman Canada and Ironman Hawaii. And then done a few ultra races as well. And just one I want to mention, including this really unique Badwater race, which I don't know if anyone's heard of before. It's this crazy 135-mile ultra marathon in Death Valley each July. So it's at 120 to 130 degrees in Death Valley in July. Now, I didn't run this race. I provided medical care for it. It starts in the salt flats of Badwater, California, the lowest point in the U.S., and then runs through Death Valley to the Mount Whitney portal, which is the highest peak in the continental U.S. Apparently, it used to run up the summit to summit Mount Whitney, but the Forest Service put an end to that a number of years ago because there were just too many people on the mountain at that time. So now they just run up to the Mount Whitney portal. But crazy race, really interesting experience. Love to talk about that at some point if anyone has questions about it. But let's go back. My day job, as Sebastian mentioned, is as medical director of the Sports Medicine Center at Husky Stadium, where I see runners, triathletes, and other endurance athletes of all ages and abilities. Primarily seeing overuse injuries. But now as I age, so have my patients, and I see a number of active older folks who, just really want to keep active, but their bodies are breaking down. And honestly, I just have to say, longevity with running or any sport for that matter is really all about training smarter and being flexible in your training as we all, inevitably age. So we can talk about that as well. But that's it for me. So, before we get started, I'd like to, just get to know you all a bit. And what I mean by that is, we're going to try this new polling feature that Sebastian helped me create. So if Sebastian, you could put up the poll, and maybe if everyone could get their cell phones or smartphones out, and Sebastian, you can kind of describe it, but can take that QR code on your camera or smartphone. We can go from there for a few questions. So first question: how long have you been running? You can just click one of those. So it looks like
Wow.
lots of experience so far.
Yeah, lots of endurance athletes in here.
Anybody else want to add? Okay. So I hope those people that don't run are walkers or doing some other sport that has to do with endurance, I'm guessing. Okay, great. Let's go on to the next slide. Next question. So why do you run? This isn't exhaustive, but it's a list that I just kind of created.
So I think this will be interesting. We have another meeting on Thursday.
I hear you on the stress relief. Great. General health benefits, stress relief are pretty big ones. Few racers out there. Okay. Great, let's go to the next one.
You got it.
So if you've entered races before, what distances were they? And check all that applies. So there's probably going to be more than one for each of you. Great, so you're pretty consistent with most of US runners. Half marathons and 5Ks are probably the most popular events out there, followed by 10K and then the marathons. That kind of fits, at least from a running standpoint. Great, all right, let's go to the next one. It's helpful. This might be our last one. Are you planning to enter a race in the next year? All right, so there are a lot of racers out there, maybe beginning racers too. All right, thanks for doing that for me. Helps me get a feel for who you all are and what your interests might be, and then just kind of get a feel for where you fit in with the group here. Great, okay. So now that you know a bit about me and I know a bit about you, for the next 30 minutes or so, I'll present a potpourri of running related items I've picked up over my years as a runner and as a running medicine physician. Clearly it's not going to be exhaustive, and I'm just trying to figure out what you guys might be interested in. So by the end, I'm happy to take questions pertaining to the presentation, or just running and endurance sports in general, if anyone has any general questions too. But we should talk for about a half an hour or so. So why do we run? Well, we used to run to catch food in our hunter-gatherer days, right? Now we have Amazon Fresh and Instacart, so I don't think we have to do that anymore, fortunately. But you did complete the poll earlier and mentioned why you run. This is a research study that looked at various reasons why people run, and they created a classification of about 4 general motivations, and those are the ones listed there. And I have to say, my motivation really spans all 4 categories. In different parts of my life, more were important than others. I've learned over the years that running truly helps me manage stress, as many of you noted on your poll as well. I do still get that runner's high. It may not be as high as it used to be when I was younger, but I do get a good feeling while and after I run. But it also helps me clear my thoughts. I don't know if you guys notice this, but I have some of my best ideas for work or home when thinking them through out on a run by myself usually. And still socially, some of my closest friends are running, triathlete, and training buddies, so I still have that cadre of people. And the physical attributes, as most of you mentioned, the health attributes are certainly a key part of why I run as well too, and I certainly gain the benefits of that. And then I do enjoy competition and racing, so the achievement part is still there, but not as much. I'm really weaning out of that phase of having to go fast, and partly that's out of necessity just from an age standpoint. But those are kind of general motivations. So really, I do really fit into all of those. All right, so now this is really preaching to the choir, right? And these are actually health benefits of exercise in general. They're not really specific to running. But I wanted to put some data up just to show how important exercise is. And maybe you can use it to encourage others, maybe family or friends, to pick up some form of exercise or aerobic activity similar to what you do. And you can see that that chart on the left side. Exercise decreases the risk of a number of very significant medical issues and medical diseases, as it states there. And then it also improves depression. It also interestingly improves SAT scores in adolescents, and it improves the rate of disciplinary incidents involved in elementary school kids as well too. So it does have some social factors also. So I don't know how many of you know Frank Shorter, but Frank Shorter's victory in the 1972 Olympic Marathon in Munich is really credited for the start of the initial running boom in the 1970s in the United States. During the 70s and 80s, runners were mostly young and male, in their 20s and 30s, more serious athletes who enjoyed the competition and were more, I guess I'd say, a loner kind of personality profile. The stereotype was the young male runner who loved to go out on long runs by himself and just kind of be by himself in the woods or something like that. Now, this was when marathon participation was, around 100,000 runners a year in the 70s and 80s. Then for a variety of reasons, and we'll talk about those in a little bit, in the 90s, running had a second resurgence that really has continued to today, mainly being driven by a change in the demographic of runners, to being more gender balanced. So There are actually more female marathon participants now. It crossed the 50% mark about 4 or 5 years ago or so. Now I think the statistics a few years ago were 50.4% of marathon participants are female. Also more diverse in age groups. So there's an older age group running races more so than there used to be. And now the average age of a marathon runner is in races is about 38 or 39, whereas before it was in the early 30s. And much more social also, with reasons for running and entering races, less to do with the competition and more to do with the experience. So destination races, like, runners traveling nowadays to races, which I certainly have done in the past. And then due to these large number of participants, and marathon participants in the U.S. now are up over 600,000 or so in a year. They're also older, as I mentioned, and maybe they're not as well trained. And I say that as a surrogate of looking for the experience over the competition, as I mentioned. And this is why we have a medical presence at races and mass participation endurance events, and why I have a role as a medical director. So, I'm just going to show some charts really quickly. This is a change in runner demographics. There was an explosion in races and runner numbers globally from the 90s, as I mentioned, but really picked up in the mid-2000s through about 2016, when race participant numbers peaked globally. And now actually, that number peaked in the US and started to fall a bit in the US, but globally, especially in Asia, running numbers are still continuing to rise. So more runners are actually in the US, and that's why these numbers are showing differently on the chart, though, or showing on this graphic specifically. So yes, there's been a slowdown in some races, but this change in 2016 really, at least seems to coincide. We don't know for sure, but it seems to coincide with the gaining popularity in non-standard races, like obstacle course races, Tough Mudder, Spartan events, and then even ultra running events too on trails, which really aren't included in this this graphic that I have here. And then, so again, it's hard to give a definite reason for the drop off around 2016, but it does, as I mentioned, coincide with this increasing popularity of other events that may be more social with a different experience than a typical road race. Again, obstacle courses, Tough Mudder, Spartan events, etc. And then the more extreme events too, like ultra running races, trail races, Ironman triathlon, etc. The marathon isn't the bucket list of people anymore. Now it's an ultra run or an Ironman triathlon. So it's just different. And this is not to say that running at all is on the decline, but there's just been a change. And then this graphic shows that drop off is really fueled by 5K and half marathon participants, particularly in the US specifically. So just some interesting stats. Not sure exactly how to scientifically, the scientific rigor of these, but it's just interesting. All right, so we've talked about the good parts of running, the health benefits, the motivation to run. So now let's talk about what I do, why I have my job as a physician and who takes care of runners and other endurance athletes in race medicine on site, but also in my sports medicine outpatient clinic at Husky Stadium. And in doing so, hopefully, I'll impart some thoughts on how you could stay out of a race medical tent and in my clinic in general, with staying healthy as a runner, walker, or other athlete. So due to the large number of participants, as I mentioned already, and that runners are older and maybe not as well trained. Again, the surrogate for that is, looking for the experience over the competition. So they might not be as well trained because they're not, racing as hard or training as hard to race. And that's why there's a medical presence at these races, because the demographics have changed. And to put on these races from a medical perspective is quite challenging. As you can imagine, I have a map of the Seattle Marathon here, because these races, are 13.1 or 26.2 miles that spread across a whole city that has a whole host of other things going on at the same time. So, in preparing, we need to have a lot of coordination with the city resources, police, fire, EMS, bus lines even. So it is quite a production to put one of these races on, and then the medical aspects of it too. And then because most medical issues happen at the finish or thereafter, we have a large medical presence at the finish line. So this is a large medical tent that we used to have at our Seattle Marathon and Memorial Stadium. These are some smaller medical tents at a half marathon we have. And this is one too. And this, unfortunately, I couldn't find our Seattle medic, so I just pulled one from the website. That's why it says Los Angeles on there. So forgive me on that one. But we have course medics on the course that are stationary, like I said, in medical stations on the course, but also roaming the course on bikes. And so here's a graphic of what we see as medical providers for endurance sporting events like marathons. And the vast majority are musculoskeletal issues. And this is a snapshot of what we see in the Seattle Marathon specifically. But it's pretty commensurate with what other races see for the most part. 62% of medical encounters in these medical tents at marathons are musculoskeletal issues. So minor sprains, strains, significant muscle cramping, etc. Then dehydration is a big one too, which makes sense in a long race. And then the Seattle Marathon, which is in late November, early December, we see a good amount of hypothermia that is, so cold, because it is cooler weather. It's usually in the 40s, sometimes 50s, sometimes even below that. It snowed a few times over the years. Fortunately, we don't see very many severe medical issues, but they certainly do present from year to year. So just want to talk briefly about what some of these severe ones. This is just one or two slides of all this stuff, and then we'll get to more overuse injuries and that kind of stuff. So there are key reasons, that I've mentioned already, why there is a medical presence at these events, and not to bring anyone down regarding participating in races, but just to discuss reality for a second, since I'm a physician and really looking into safety of these events. Cardiac arrest incident is 1 in 100,000 runners, and that's pretty well defined in a marathon. So the larger events like Chicago and New York, they have about 50,000 runners a year. Statistically, we'll have a cardiac event every 2 years or so. It's quite a bit. So we always have to be prepared for this. And so that's that first picture. The second picture there down below, where a runner's getting water, is just a surrogate for hyponatremia. So not an overly common issue, as runners are more educated in hydration strategies. But in the early 2000s, this was a bigger issue. And what hyponatremia is low blood sodium from drinking too much water or other hypotonic fluids, and Gatorade and a lot of sport drinks are hypotonic to blood. And thus diluting these hypotonic fluids, if you drink too much of them, can dilute your blood sodium levels. That can cause some people to be severely ill, actually. Usually manifesting as mental status change, so not thinking clearly and eventually potentially passing out. And to prevent that, most folks need to have a planned hydration strategy for these longer distance events and stick with it. Knowing how much fluid you need according to the race and environmental conditions is really important in a key safety event in running these longer distances. Now, I'll say this, fortunately, to dilute anyone's blood sodium levels in a race by drinking too much is really hard to do unless you're drinking a lot, meaning drinking multiple cups at every single aid station and then drinking between the aid stations too. So those people in the 2000s that used to carry fanny packs with lots of water and then would stop and refill them and drink more water at every aid station, those are the ones we'd have to be more concerned about this kind of thing. And fortunately, it doesn't happen that much anymore because people are more educated in it. And then finally, that third picture is heat stroke. So these are kind of the three things that I talk about with my medical team that can actually kill or really harm a runner. So heat stroke is one of them, and this can happen at any ambient temperature. And we see runners come in the Seattle Marathon when it's 40 degrees with heat stroke in our medical tent, with temps of 105 to 107. Sometimes I've seen a couple of 109 even every year. So pretty ill people with these temperatures that high. And it has to do with how much the runner generates and dissipates heat. So not necessarily related to the ambient temperature. The way to treat this is putting them in a ice bath, or diagnosing it to know that that's really the issue, and then getting them in an ice bath quickly and getting their temperature down as quickly as possible before you transport them in an ambulance, because ambulances don't usually have these cooling strategies specifically. So we do that in the medical tent. All right. So one last thing about marathon medicine is this diagnosis of exercise-associated postural hypotension. So a long word for low blood pressure. So this is the most common cause of someone collapsing at the finish line of a long distance race. And it's the exact reason why there are finish line catchers. So if anyone's done probably a half marathon or marathon, you always see a lot of volunteers at the finish line. And what they're designed to do is really help the runners keep walking once they stop or once they cross the finish line. So they don't just stop and rest, they keep walking. And the reason for that is to prevent this, which is, again, postural hypotension or low blood pressure. And what that creates is venous pooling in the legs specifically, so blood pooling in the legs. So pathophysiologically, but while running, an athlete's contracting leg muscles, so the calf muscles specifically, act as a venous pump. So it facilitates blood return to your central circulation, so to your heart, which then can pump blood to your brain and keep you maintained. So upon cessation of exercise, so your legs stop working after you've been using them for 13 miles or maybe 26 miles, your body's not used to that. And if you stop quickly, your calf muscles aren't working anymore. And then your blood pools in your legs, doesn't go back up to your heart, and your heart then can't pump all that blood to your brain, and then you pass out. And so treating this is really prevention, first of all. And it's by having runners keep moving and acclimating to not running and not being so reliant on their calf muscles. So that's why we have a lot of volunteers just keeping runners walking past the finish line so they don't just stop. Then if that doesn't work and they do stop or they still get lightheaded, then they come to our medical tent and we have them rest lying down with their legs elevated. It's called the Trinella brick position. And then we orally rehydrate them. And usually that works just fine. They can get better within about 30 minutes or so with no issues. Every once in a while, someone might need IV fluids to turn them around, but that's really pretty rare. And it's very uncommon for medical tents to have to give IV fluids to people to get them better. All right. So let's move from marathon medicine to just overuse running related injuries specific. So here's just a graphic of what an everyday runner might have with regard to running overuse injuries specifically. And it's unfortunately quite common. Up to 85% of runners in some studies have been shown to have an overuse injury, I think within the first 18 months of novice running specifically. Most common ones are knee injuries, but you can get medial stress syndrome, so shin splints, lower leg, Achilles tendinopathy in the ankle, and then plantar fasciitis in the foot. I'm sure some of you that have been running for more than 5 years have probably had a few of these. I've certainly been running longer than that, so I've had a number of these as well too. And regarding risk factors for running related injuries, so training errors, doing too much too soon, and increasing or having really significant training loads is a risk factor. And another risk factor really is prior history of lower limb injuries. And that's really what's panned out in the literature. And so what hasn't been shown to be a clear risk factor is shoes, training surfaces, running gait specifics, malalignment issues of the body, stretching, orthotics, all those things, and haven't been shown actually. And it's really more so due to research methodology and challenges. So this isn't to say that these don't contribute to risk. So it's not that the absence of proof is the proof of absence, right? But they have not been proven in many, many studies evaluating risk factors related to running injuries over many, many years, actually. So we can't hang our hats on any of that stuff, but we do still think about these things as possible reasons for why people might have running injuries, because they are things that we can change and they make sense to a certain extent, but we haven't just been able to prove them. Really, the only thing that's been proven is if you have a history of lower limb injury, which makes sense, and then some training errors, doing too much too soon. So what do I see? So, given the research is inconclusive, I thought it would be helpful to review, some of the common patterns and issues I see in my practice regarding running related injuries, but realize my bias and interest is biomechanics and correction through rehab. So I just want to, put that out there. Clearly, as I mentioned already, training errors are an issue for sure. We can talk about that at some point during the question and answer if you want. But let's discuss just some common biomechanical faults that can be addressed through rehab and potentially gait retraining. And I'm really just going to talk about 3 big ones that are pretty common. And this is probably the biggest one. So one of my colleagues, Mike Fredrickson, who's a physician like me at Stanford, actually, shared these pictures with me and called this the maintaining a knee window. And it's really creating stability in the hip and pelvis. And the reason it's called creating a knee window is, or maintaining a knee window, is because the second picture will show it better. So this first picture is you have a pelvic drop here. So your stance phase leg, the gluteus medius muscle, which I'll show in a second, is weak, and your hip pushes out this way, and you drop your left hemipelvis, so the stride leg. So you have this kind of imbalance in the pelvis, and therefore you don't see the knee window in between the 2 knees, right? Now, if you have good stability in your pelvis, you're going to have this nice cross here where it's just straight across. There's no drop in the pelvis. And you have a nice knee window where you can see between the knees. So this is the ideal. This is where, unfortunately, a lot of runners fall, including myself at times. And part of that is because runners in general, we don't play soccer and tennis where we're going from side to side, right? We just go run forward. So we have our good butt muscles and hamstring muscles, but not our side hip muscles to control our pelvic obliquity and the way our pelvis rotates from side to side. So if we don't play soccer and tennis, we don't use those muscles very effectively, very well. And therefore, if we have this drop in our pelvis, we might have think about this, 1,000 foot strikes per mile about, right? So if you're running 5 miles, that's 5,000 steps over the course of that 5 miles. And then all the muscle imbalance that's creating with regard to forces that are going through the leg, coming through the hip, the back, the knee, the ankle, etc., are coming in, gaining over time, and that's where overuse injuries can present. So just really quickly, just to keep you all on the same page with me, the gluteus maximus is the big butt muscle that everyone can see and feel, right, that you're sitting on right now. The gluteus medius is a smaller gluteal muscle that's on the side of the hip that comes from the back, goes to the side, and inserts on this greater trochanter on the side of the hip, and that's the muscle we're talking about. So if it's weak on the stance phase leg, you're going to drop your pelvis to the other side. So this is how I test it in the clinic, but this is what you can do by looking in a mirror. So that blue shorted guy is what we should look like. You can see the knee window really well here. Pelvis is nice and level. So this is a picture of a friend of mine who has his shoes on right here, but you see he doesn't have a good knee window like he does here, right? And he drops his pelvis on the stance leg. His pelvis is higher, and on the other leg, his pelvis is lower. And then what shows here is he takes his shoes off too. And look what happens. He even falls apart even more. So the pelvis drops even more, and the knee window even closes more. So this is kind of a double whammy here. He has weakness in his hip girdle, which shows up here, but he also has very flat feet and overpronates. So when he takes his shoes off, which have these pretty built up shoes with a good arch support, his foot collapses more, and therefore he falls in even more into this deviation pattern. So this is someone who really has to work on foot stability, but also pelvic girdle and core stability. Now, this is a way a lot of physical therapists will teach people called the clamshell, which I don't see very useful for runners because this is a pretty basic exercise that works well for people, in my opinion, that have had a hip replacement, that have had their hip muscles cut through, and they really need a lot of neuromuscular retraining of those hip muscles. This is a good exercise to start with. But for a runner, it's really too basic. And a lot of runners that go to potentially physical therapy or learn this exercise quit pretty quickly because it's so basic, it just doesn't make sense to them. So I usually start runners in something like this, where at least if you have to start out slow, you can do something in side lying here. And this is a picture to show it. Say it's against the wall here, and you want to be against the wall when you're doing the side lying hip abduction, which is strengthening that gluteus medius muscle I was talking about. And the reason you want to do it against the wall is because you might cheat otherwise. If you're not against the wall, then you might cheat. And many people, runners specifically, will go into a little hip flexion, so move their leg forward a little bit, and therefore they're using a different muscle. As opposed to the gluteus medius, they're using the tensorofascial lata, which is the TFL muscle, which allows you to hip flex, meaning move your hip out that way, but also raise it up like this. Whereas you want to use the gluteus medius, which is raising it up this way specifically. So that's why I like to say, have your butt, shoulders, and heel against the wall, and then raise your leg up against that wall. So you're using the gluteus medius and activating more. If this gets really easy, then put ankle weights on, on your ankles here, or put ski boots on to make the load a little bit stronger. Now this still isn't functional, right? We don't go around bringing our leg out to the side like that. So it's a strengthening exercise to strengthen that muscle, but it's not a functional exercise. Functionally, if you can handle it, if you can do that already, you can recruit that muscle well, then you can do things like this, like step ups and working on a Basu ball to more functionally recruit that muscle. There's lots of other ways that physical therapists and other people can teach you to functionally recruit these muscles, like step ups, lunges, Superman poses, monster squats, like over here too. So lots of different ways to work on this. All right. So two more. That was my big one because that's the biggest thing I see is gluteal strength issues in runners. And again, because runners don't do a lot of tennis and side-to-side sports like soccer. So the second tip is a slight forward lean. And what that means is having really strong butt muscle. So I talked about the gluteus medius, but also the gluteus maximus, or the hip extensor. So hip extension is bringing your leg backwards. So bringing it back like this here. And that's the gluteus maximus that helps with that, the bigger butt muscle. So if you have strong butt muscles, you can lean forward a little bit and still stand upright. If you don't have strong butt muscles, you're going to fall forward if you try to lean forward. So that's why this runner who doesn't have strong gluteal muscles wants to stand more upright. And therefore, this puts more stress on the knee specifically. So if you have a more forward lean, even just a 7-degree lean, can result in decreased stress on the knee specifically. So that's one thing to kind of think about as well, to forward lean a little bit. And then the third biomechanical thing that I wanted to look at was landing with your foot under the center of mass. So the goal here is really midfoot striking. I don't want to get into the details too much of this. We'll just talk about it a little bit. We can talk in the question and answer session if you want to more about this. But instead of heel striking, which you can see here when you land with your foot not under your center of mass, so it's in front, you heel strike, right? And if you're landing with your foot at the base of your center of mass, then you're more midfoot striking specifically. Heel striking induces a braking motion, so you kind of stop And that creates an extra force, a ground reaction force that goes up your leg, which then can potentially create an overuse injury specifically. So landing on your midfoot here, in this pic to the left here, with your center mass over your foot helps dissipate those forces a little bit more. And actually has been shown to decrease energy expenditure as well too. So it gives you more energy to actually run as opposed to focus on the forces. And one way to practice this is periodically run barefoot. And because when you run barefoot, you're not going to heel strike because that's going to hurt your heel too much. Because built-up shoes really allow us to run with a heel striking method because there's so much cushioning in them. Another way to consider practice if you're not wanting to run barefoot on softer ground is to think about your running cadence. So if you can increase your running cadence up, and there's not a good research on this, so it's hard to say what the real number is, but there's a number thrown around about 180 steps per minute. So 90 steps on each foot per minute. That generally shortens your stride. So it brings your stride, it brings your foot strike in so that you're not bounding so far and you're not reaching so far ahead and creating that heel strike. So if you increase your running stride rate or increase your cadence, you're usually going to bring your foot in. You're going to decrease your stride distance, which shortens that stride and pulls your foot into a more midfoot striking pattern. So that's another way to kind of practice that also. All right. So another question that my running patients ask a lot is, what's the best cross-training method for an injured runner? And, they're worried about fitness when they're needing to convalesce during recovery from an injury. I certainly have worried about it. If it's a stress fracture, Achilles tendinopathy, or just runner's knee, if you have to rest, you get worried about fitness if you're a competitive runner specifically. And to a certain extent, they're rightfully concerned. The statistics show that, or the research shows that given a well-trained endurance athlete, they can experience a 7% decline in VO2 max within about 2 to 3 weeks of cessation of training. So that means less cardiovascular fitness. It means less capillary density in your muscles, so less blood flow to those muscles over time. And thus there's a significant rebuilding period that you have to do to get back to your pre-injury state of fitness. So we have a good discussion about, how to maintain fitness and consider cross-training. And that's what, I'd like to end this presentation with today, is just discussing some of these cross-training modalities. And this list here is really in order of sports specificity, with swimming being the least sports specific for a runner, and then anti-gravity treadmill training being the most specific. We'll focus on these two specifically. But the theory of sports specificity says effective cross-training has to have a training pattern equivalent in intensity and duration of the original mode of exercise. So any of these really fit that if you train hard enough. But then replicating the range of motion and muscle recruitment patterns. These don't really follow that as well. This elliptical training does a little bit, but not as much as for a runner as deep water running or anti-gravity treadmill training. So I want to focus on these two specifically because many of you may not be aware of these activities that much. So deep water running, so this is running in the deep end of a pool or diving well while wearing a flotation device. People that are at the U, specifically here in the Seattle campus, we have some benefits of joining the IMA, which has a deep diving well pool, which I've lived in many years ago when I was injured. Now I feel a little bit older and I don't necessarily like to go there as much because there's so many younger people there, but that's just me. But many studies, primarily 30 years ago or so, demonstrated an important training effect in athletes who deep water run. And I mention this regularly in clinic to convince runners who want to continue training, but need to offload some leg injury to consider deep water running as a cross-training method. And what I really focus on when I talk about that is this really, that in many research studies, it's been shown that runners can maintain 2-mile and 5K run performance. So functional performance can be maintained just solely deep water running, if you deep water run right. And we'll talk about what that means specifically in a second. Now, some studies have even shown that runners can improve, not just maintain their aerobic fitness. Now, studies do better in this category with less fit runners. And that makes sense because improving a highly trained runner with deep water running is a little bit difficult. There's just less margin to get them better. But less fit runners can really improve their VO2 max, which is sole deep water running specific. So something to even consider about if you're prone to overuse injuries, maybe add deep water running into your training so you're not running on land so much, maybe decreasing the risk of overuse injuries. All right, so I mentioned earlier that I was going to talk about some training tips for deep water running specific. So this is one where you don't want to just transmit your land running workouts to the pool. So don't do your long, slow distance in the pool. One, because it's monotonous and really hard to do a long run in the pool. But two, because it's not as effective. There's a higher percentage of deep water running sessions should be at a harder effort. And it's because your body can handle it, first of all, because you're in the water, so you're not pushing against the ground and therefore having the risk of overuse injury. So less injury risk from speed workouts such as would be on the ground, and it's less taxing because you're not weight bearing like you are on land. Now, this is, I just checked this recently. This is open access. So if anyone wants to, jot this down, this is a article that I put together with my fellow who's now an attending physician here with me at Husky Stadium, and then a triathlon coach here in Seattle. And we have some, it's for stress fracture management specifically, but it talks about some deep water run training workouts specifically, so you can get a feel for what some might be if you wanted to. All right. So practical recommendations. So gradual familiarization is important because it is a little bit different mechanically speaking than running. So it takes a little bit of while to get used to it. You want to wear a flotation device though, and that's because it helps you stay above the water, and most runners don't have a lot of body fat, so we tend to sink in the water, so you're not very buoyant. And then it also helps you just so you're not struggling to keep yourself up above the water, and then you can focus on form more. And then, as I mentioned, harder workouts are better and more tolerable. So doing interval training, fartlek training, etc., that kind of stuff is reasonable to do in deep water when you're deep water running. And like I said, you can maintain and potentially even improve your performance with deep water running. That's what I really try to sell deep water running for as a cross training modality to my more competitive runners that want to try to keep fitness while they're injured. All right, so the last thing I want to talk about is anti-gravity treadmill training. So how many of you have seen one of these? And if you run on one of these before? I have, and it's really kind of interesting. It was designed by NASA engineers to work on trying to figure out how to exercise people or astronauts in space to keep their bone density up. So there's an internal force plate or a scale that is embedded in the treadmill to weigh yourself. And then you're enclosed in this device from your waist down to off-weight yourself. So you can unweight yourself from 100% body weight to 20% body weight in 1% increments. And it's used for rehab as well. So it's nice for stress fracture management and rehab because a return to running plan with stress fractures usually need an incremental protected loading of the bone to facilitate healing. So this is a great way to manage a stress fracture to get people starting to run again when they can tolerate it, to really gain that tissue tolerance for returning to safe running. It's also used actually in nursing homes for stroke rehab, Parkinson's disease, and even osteoarthritis. We use it in our Husky Stadium more for athletes though, runners. And here is, I think I have a video here. Let's see if I show it. I don't think it's gonna load. Let's see.
Is it embedded in the presentation?
It is, and I think it's got the presentation stuck now. Unfortunately, let's see here. There we go. Let's see. I went back and forth a few times, so it's just going to be slow. Yeah. There we go. Okay. Let's see if it runs. Just bear with me. I'm going to give it a second and see if it will. Maybe it won't run. I want to say something about anti-gravity treadmill training, though. There's not a lot of research here, so it's really in its infancy. It's been around for 15 years or so, but there's not a ton of research to say like how really best to do this and what it really does specifically. So it's more conjecture. So just be careful with that. So don't take anything too strongly with what I say. There are about 19 or so I counted on the website, the Alter G website, which is the company that makes these in the Puget Sound area. 12 are in Seattle or so. We're in Seattle in the suburbs specifically. We have one at Husky Stadium, and yeah, bummer, it's not going to show. It's my only video too. Oh well, okay. So I can't show that. Okay. So keep things moving forward. So training tips for anti-gravity treadmill training. So keeping your butt for healthy runners, we'll talk about healthy runners, then we'll talk about injured runners. So for healthy runners, you want to just cross train. For injury prone runners that may not want to be running on land all the time, keeping your body weight percentage at 85 to 95% would be reasonable and speeds high to normalize motor patterns, which is more sport specific because your motor patterns are a little bit different in the anti-gravity treadmill still. And if you ever run in one, you'll realize why. So you can supplement land running with high intensity interval training or fast paced intervals and tempo runs on an anti-gravity treadmill. So it's something where you might get less injured, but still be able to get that fast pace in. Now, for injured runners, we usually start runners at about 50 to 65% of their body weight and really determining what's acceptable on an individual basis where there's no pain. And we usually stay there for about a week or so at a minimum, and then increase by 5 to 10% per week. Again, this is generally speaking, every athlete's an individual, but you want to make sure you have no pain during running or after running. And then we usually move people to land-based running after they're comfortable running at about 90 to 95% of their body weight or so. And then land-based running, not like deep water running, can be transferred to anti-gravity treadmill training for the most part. So that's kind of easier. So your regular workouts on land can be done on the treadmill. And then, last thing, if you're interested in thinking about your cadence, then you could use a metronome. All our apps on our phones have metronomes that we can, you can download a metronome app, and you can put that on the treadmill and focus on your cadence and try to get your cadence to, whatever, if you want to try to get it up to 180 per minute or something like that, that might be reasonable to do when you're trying to pass the time on a treadmill like this specifically. All right. So I'm going to close here. So I just want to kind of wrap things up by talking about just some take-home points that I just mentioned from a runner safety and health perspective. So there are common medical conditions in race medicine that we talked about, and some ways to prevent them from happening to you are consider a hydration plan for racing in different distances and different environmental conditions. And then remember I said about don't stop abruptly after you finish that race, but instead continue to walk after you pass the finish line, just to let your body equilibrate to not running again, but you're still moving and walking, making that blood flow pumping from your legs back to your heart and back to your brain so you don't pass out. Then prehab or prehabilitation and rehab or rehabilitation for common biomechanical factors, may contribute to running-related overuse injuries. I say may because, again, the research doesn't define this very well. But in my, experienced hands from a temporal standpoint, I've been doing this a long time, there's hip and pelvic girdle strengthening is important. So controlled single leg squats are a reasonable thing to consider in your general prehab program. And then I mentioned that slight forward trunk lean. So if your gluteal muscles are strong, you can probably trunk lean a little bit when you're running. And then remember midfoot striking. So landing with your foot under the center of mass is probably beneficial as well too. And then lastly, the last things we talked about were effective cross-training strategies such as deep water running. Don't forget to wear a flotation device if you do that. And then I'm sorry that the video didn't show up for the anti-gravity treadmill running too, but kind of a novel or interesting way to approach it if you have access to that. And I will leave it at that and open it up to questions. I think we still have some time. So yeah, I'd be happy to stay around for questions if anybody has any or want to open up to discussion.